Victorious. Heart versus brain, an anesthetic management for brain abscess in a patient with congenital heart disease. I present to you a case of a 4-year-old boy with a chief complaint of right-sided weakness. Present condition started 2 weeks prior to admission when he had episodes of intermittent fever with associated frontal headache. 6 days prior to admission, symptoms were accompanied with decrease in appetite and cough. Consult was done and antibiotics were started. However, 2 days prior to admission, patient was unable to get up from bed and move his right upper and lower extremities with noted incomprehensible speech. The mother opted to observe the patient's condition until 1 day prior to admission due to the persistence of right-sided weakness with recurrence of headache. Consult was sought and patient was subsequently admitted. Patient is a diagnosed case of tetralogy of Fallot at 2 months of age, however untreated. At 1 year old, he was admitted for pneumonia. On admission, patient was awake, conscious, afebrile, and cyanotic. The following were the initial vital signs. Precordium was dynamic and a grade 4 systolic murmur was heard. Nail beds were cyanotic with noted clubbing of fingers. There was medial deviation of the right eye and shallow right nasolabial fold. Patient was responsive to pain on all extremities, however. Motor strength was 0 out of 5 and deep tendon reflex was graded as +3 at both upper and lower right extremities. Cranial CT scan revealed multiple abscesses in both cerebral hemispheres with hemorrhagic component in the left and with increased leptomeningeal enhancement. Initial complete blood count revealed hemoglobin of 206 mg per deciliter, hematocrit of 0.63%, and white blood cell count of 17.72. Initial electrocardiogram revealed right axis deviation with right ventricular hypertrophy. On pre-op evaluation, patient was classified as ASA class 3E. The patient was scheduled to undergo emergency bilateral burr hole with JP drain placement under general endotracheal anesthesia. Initial vital signs were the following. Anesthesia was started with midazolam 1 mg and ketamine 20 mg. Pre-oxygenation was done to reach an oxygen saturation of 88%. Sevoflurane was started with a minimum alveolar concentration of 3. Rocuronium 8 mg was then given, then patient was smoothly intubated. Surgery lasted for 38 minutes. 60 ml of brain abscess was drained. The following vital signs were noted post-operatively. After the operation, patient had good gas exchange and spontaneous breathing. He was then extubated and brought back to the pediatric intensive care unit. After 2 hours, patient was fully awake with stable vital signs. On the second post-operative day, there was noted improvement of the motor strength of the right lower extremity, graded as 3 out of 5, and deep tendon reflex of +2. Vital signs remained stable, and the succeeding hospital stay was unremarkable. Tetralogy of Fallot is the most common congenital heart disease. The following are the components of tetralogy of Fallot. The degree of pulmonary arterial stricture usually determines the severity of the disease. The presence of right to left shunting leads to poor pulmonary perfusion, chronic hypoxemia, and cyanosis. The occurrence of brain abscess is quite common in patients with cyanotic congenital heart diseases. In a study by Raha et al., they stated that 13 to 70% of all brain abscess cases are accounted for by cyanotic congenital heart diseases, most especially tetralogy of Fallot. This is a comparison of the anesthetic goals for patients subject to undergo surgery with a coexisting congenital heart disease versus a neurosurgical condition. Raghav-Bavendra cites 5 anesthetic goals, which includes avoidance of hypoxemia, maintenance of adequate hydration and systemic arterial blood pressure, minimizing pulmonary vascular resistance, and prevention of sudden increase in systemic oxygen demand. While the anesthetic goal for patients who will undergo brain surgeries include prevention of increase in intracranial pressure, cerebral hypoxia, hypercapnia, and volatile anesthetic-induced increase in cerebral blood flow. Anesthetic induction causes vasodilation, resulting to a decrease in systemic vascular resistance, consequently increasing the occurrence of right-to-left shunting in patients with tetralogy of Fallot. The induction agents preferred for patients with this disease include ketamine and etomidate because these drugs increase systemic vascular resistance and does not increase the right-to-left shunting. For neurosurgical patients, intravenous induction with thiopental and propofol is ideal to prevent increased intracranial pressure. This is a tabular comparison of the effects of propofol versus ketamine. Propofol is a popular hypnotic agent and is known to cause decrease in vascular resistance and arterial blood pressure, making it the preferred agent in neurological operations. However, these effects lead to desaturation and decrease in systemic perfusion, especially in patients with cardiac shunting. Ketamine, on the other hand, is ideal for patients with cardiac shunting because it is able to maintain the hemodynamic status. Ziller et al. Conducted a systematic review of literatures which showed that ketamine does not increase intracranial pressure. In fact, according to Jorkman et al., ketamine has been shown to decrease cerebral blood flow and cerebral spinal fluid pressure in animals and has no effect in anesthetized humans. In one study, pediatric patients with sustained elevations in the intracranial pressure were given ketamine to decrease intracranial pressure or to prevent further elevations during procedures. In conclusion, they stated that ketamine is an appropriate induction agent for rapid sequence induction with suspected intracranial pressure and normal blood pressure or hypotension. This is a case of a 4-year-old boy with an uncorrected tetralogy of Fallot who developed multiple brain abscess, and the dilemma regarding the appropriate agent for anesthetic induction exists. The brain and the heart are two vital organs that should always be preserved and protected. Two of the commonly used and available induction agents include ketamine and propofol. These two drugs offer their unique advantages but should always be used with caution. In children with congenital heart diseases, ketamine is preferred because of its ability to maintain systemic vascular resistance. Propofol, which does the opposite, may eventually lead to desaturation and worsen the patient's condition. Where two conditions simultaneously exist, a wise and thorough decision-making is needed together with caution and vigilance, with the goal to protect both the heart and the brain.
Dr. Leah.
Okay, congratulations for your success in managing this patient. I would like to know the mechanism of ketamine because before they used to say that it increases your cerebral blood flow and therefore will increase your intracranial pressure. But things have changed. Even 2 or 3 years ago, it was reported that ketamine can be used in neurosurgical procedure. Now, I want to know how ketamine, the mechanism of action of ketamine, why it can be used without elevating your intracranial pressure or your increasing your cerebral blood flow.
Dr. Ketamine is an NMDA antagonist po. In the cerebral blood flow, mainly it causes vasoconstriction po. So, it limits the...
Aside from blocking your NMDA, what other what other actions does your ketamine have that will qualify it to be used in a neurosurgical procedure? It is not enough that you know that it blocks your NMDA. Marami pang mechanism of action yan na it really helps your maintenance of a normal neurosurgical procedure.
Dr. Generally po, ketamine is...
What are the opiate receptors that are affected with your ketamine?
The mu receptor po.
What else? Ano Ano pa? There are two.
I am not sure.
Remember that what does ketamine do? Ano ba yung dissociative anesthesia, is it na? So what's the other receptor? Opiate receptor.
I will read on that.
So whenever you, whenever you put your the dose of your medications, you also try to put the according to weight or the correct dosage, not just the amount or the like for your ketamine you put 20 milligrams. So how much does it cost per kilogram?
It's supposed to be 1 milligram per kilogram. Computed dose.
1 milligram per kilogram.
So if that would be based on the weight of the patient, about 13.5 milligrams.
But so based on the weight, it
However,
will become 13 point something,
yes,
but
po.
you gave it 20.
Yes, po.
Alright, thank you. Thank you, Dr. Olivia, for the presentation. For our 12th presenter, may we ask Dr. Gina Gumintad from the floor. Okay. To present acute severe heart failure is a rare complication of resection of a large anterior mediastinal tumor in a pediatric patient, a case report. Give her a round of applause.
Nawawala sa
A pleasant day, everyone. Presenting a case of severe heart failure as a rare complication of a section of a large anterior mediastinal tumor in a pediatric patient. We are presented with a 7-year-old male child with a large anterior mediastinal mass who underwent excision under general illustrated anesthesia, who subsequently developed acute severe heart failure. Our objectives for today is to be able to impart basic knowledge of the anatomy and physiology of a pediatric patient with an anterior mediastinal mass. We will recognize presenting signs and symptoms and discuss the appropriate perioperative test and come up with perioperative risk stratification in order to come up with proper anesthetic management for the patient. So we have a 7-year-old male child weighing 18 kilograms with no comorbids, had an unremarkable maternal and birth history, who presented with worsening dyspnea and orthopnea for the past 5 months. Previous biopsy showed mature teratoma and yolk sac tumor. The patient had recurrent nosocomial pneumonia treated with antibiotics, which caused the delay of the elective surgery. Further workup revealed chest X-ray revealed near total opacification of the right atrium and part of the left ventricle, and the superior vena cava is also obstructed. Echocardiography revealed a normal ejection fraction of 83% with evidence of a large mass compression of the right atrium and part of the left atrium, as well as the superior vena cava. CT scan noted a complex anterior mediastinal mass measuring 11.9 by 8.6 by 12.3 centimeter extending to the right hemithorax, which compresses the lungs and also the right main bronchus. So during this time, efforts were made to correct the anemia. Also, JAB chemotherapy was initiated with JM8, carboplatin, etoposide, and bleomycin. However, on the 24th day of admission, the patient presented with cyanosis and worsening dyspnea. Oxygen saturation on room air dropped to 75 to 80%. On face mask improved to 85 to 90%. The patient was subsequently intubated awake by a pediatrician in the ward and was placed on mechanical ventilator, placed on 100% FiO2. Post-intubation ABG revealed respiratory alkalosis. On the 25th day, the patient was brought to the OR for semi-emergency excision of anterior mediastinal tumor. He was received intubated. The patient with the following vital signs: tachycardic at 140, oxygen saturation of 94%. Anesthesia was induced with midazolam 0.1 mg per kilogram, ketamine 2 mg per kilogram, fentanyl increments of up to 7 microgram per kilogram with sevoflurane 0.8 to 1 mAp, and placed on controlled mechanical ventilation. Rocuronium at 0.5 mg per kilogram was given prior to surgical cutting. The patient was then placed on soft left lateral decubitus position. Right posterolateral thoracotomy was done, exposing a large reddish mass, partially obscuring and pressing on the heart. However, during this time, the saturation was noted as low as 80%. Even with FiO2 of 100%, there was continuous blood loss. Dopamine was started at a dose of 5 to 10 microgram per kilogram per minute. Blood transfusion was given, a total of 3 units PAC RBC. Point of care testing was done, which revealed compensated respiratory acidosis with mild hypoxemia, hematocrit of 0.28 and hemoglobin of 97. This was the highly vascularized large tumor that was resected. During hemostasis, there was a note of decrease in oxygen saturation up to 60% with weak cardiac contractions and hypotension. Epinephrine bolus was given and also infusion was started. However, there was weak cardiac contraction. ACLS was done. Also a note of ventricular fibrillation, which was resistant to external shocks and medication. A total of 60 minutes resuscitation was done. However, the patient expired. So in the pediatric population, most masses are found in the anterior mediastinum and they are mostly malignant. In order of frequency, they are the lymphomas, germ cell tumors, mesenchymal tumors, and thymic lesions. When faced with a pediatric patient with anterior mediastinal mass, we have to determine the signs and symptoms, which as orthopnea, cough in the supine position, wheezing or stridor, dyspnea on exertion, superior vena cava obstruction, jugular vein distension, increased work of breathing. All of these are manifested by our patient. 3 main tests in predicting development of potential cardiopulmonary symptoms, which include the pulmonary function test, transthoracic echocardiography, and CT scan cross-sectional area. Blanc and D'Souza have this stratifying pediatric patients into categories of intraoperative risk based on their presenting signs and symptoms. They can be categorized as low risk, intermediate risk, and high risk. Our patient is categorized as high risk with the presence of orthopnea, stridor, and cyanosis with compression of the great vessels, the superior vena cava, and also the presence of tracheal compression. So what happened to the patient? Few minutes after complete dissection and excision of the anterior mediastinal mass, there was sudden desaturation, hypotension, and cardiac arrest. So when presented, due to the large mass effect, there was compression of the pulmonary artery, which resulted to a diminished venous return to the left side of the heart, resulting to a drop in cardiac output. There is inadequate diastolic filling, which could have resulted from the compression of the heart by the mediastinal mass. There was a sudden decrease of pericardial pressure, which led to a disproportionate increase in end diastolic volume of the right ventricle compared to the left ventricle, and a temporary mismatch of ventricular outputs. There was also the presence of a high peripheral vasoconstriction and volume overload, which caused acute left ventricular wall stress and left ventricular failure after the decompression. Some authors refer to this phenomenon as the pericardial decompression syndrome, in which there is sudden ventricular failure either on the right heart or on the left heart, which is present in 4.8% of patients after drainage of a pericardial effusion or excision of a large mediastinal mass. So for our patient, the concomitant and precipitating factors are the pre-existing right ventricular dysfunction, the reduced sympathetic stimuli after excision of the tumor, and the myocardial stanning, which is due to a mismatch of oxygen distribution across the myocardial wall, as well as an altered coronary perfusion. So how do we manage this patient? Some authors advocate avoidance of the use of muscle relaxant. Some describe the modality of awake intubation followed with opioids and muscle relaxant. Dysrhythmia should also be managed by maintaining adequate pain of anesthesia, maintaining optimum preload and afterload, with blood transfusion as deemed necessary, as well as correction of acid-base and electrolyte abnormalities. Inotropic drugs should be used, and if warranted, epicardial pacing. Concerning the role of cardiopulmonary bypass in the management of mediastinal mass, recent studies stipulated that standby cardiopulmonary bypass is not a wise option. In case of emergency, it would still take up to 10 to 15 minutes even for a trained perfusionist to come up with the whole setup of the bypass machine. Instead, what has been advocated is the use of an alternate mode of oxygenation from the beginning of anesthesia, like an extracorporeal membrane oxygenation or cardiopulmonary bypass. Thank you.